please remember to turn your camera on so that we can comply with all open meeting laws. So please have your camera on while you're voting. And with that, Dr. Grigsby, I'll turn it over to you.
Okay, thank you. I can't see all of the participants, but I can see that we have at least one other member of the TAC. How many members of the TAC do we have on currently?
Courtney Smith is here.
And Sherry Dymar is here.
Okay,
Alicia Watley is here.
great. Okay, so we are currently one member shy of a quorum, is that correct? I believe we had a quorum last time and we had Michael with us, correct? Okay. Okay, let's go ahead and get started. I apologize for any background noise that you guys may hear. There's a new member of my family who's quite rambunctious and noisy, so I apologize in advance for any unusual noises that may come through during this meeting. So I will try to stay muted as much as possible. I believe the first order of old business is the data request we had from DMS on school-based mental health resources. Does anyone have a report for that?
Hi, this is Erica Davis. I do have a report for that. And Kelly, will you let me know if I'm able to share my screen now?
You should be able to share your screen. I'm having a lot of technical difficulties. So let me know if you can.
Okay, are you able to see the PowerPoint?
Yes.
Okay, great. Okay. Okay, so we'll go ahead and get started. The request was for some updates on the school-based behavioral health services. And mouse wanted to lose me there. Okay, so I'm not sure how much you all know about the school-based services, so I'm going to give a little bit of background. Since 1988, Medicaid has reimbursed schools for any services that have been provided to children that have an individualized education plan and that are also members of Medicaid. And schools are not required to participate in the school-based Medicaid services, but they are required to provide all the services that are listed in a child's IEP. And so whether or not they get funding from Medicaid, they're still having to provide those services, but Medicaid would provide some reimbursement for them to help cover those expenses. Then in 2014, Medicaid did a rule reversal for free care, which meant that as long as a child was a member of Medicaid, any service that is provided to them that is a covered Medicaid service, that school could be reimbursed. And Kentucky submitted a state plan amendment and had that approved in 2019. So any service that is provided to a Medicaid member that is medically necessary, that's a covered service provided by a credentialed practitioner, can be reimbursed to the school. And there's one additional requirement, and that is that whatever that service is has to be offered to all students in the school at no cost to the students. And the Medicaid in Schools program in Kentucky is, we contract with the Department of Education to administer the program. So they take care of all the administrative functions, the random moment and time study, those sorts of things. And the school districts themselves are the ones who enroll as Medicaid providers. And the way that the reimbursement is done in the schools is through a cost settlement process. So the schools will submit claims throughout the year, and they are given an interim rate. So it's not the full reimbursement. It's an interim rate just to provide funding to them to, it's a cash flow. It provides funding to them so they can continue to do the services. And then at the end of the year, there is a cost settlement. And that's where all of the claims are tallied up, and we make sure that any service that is done, they get the full reimbursement for. And the year 2021 through 2022, there were over 400,000 claims that were paid for the Medicaid in School. Of those, only 10,945 were in the expanded access. And remember, the expanded access are the ones that provide a greater number of services to all students in the school. And I will not belabor the point. We know there's a mental health crisis among the youth in Kentucky. These are just a few of the example stats that we have out there, just showing how bad the situation is. And the thing is that most students are their first resource for getting any sort of mental health services are going to be in school. That is, they all have access to school, but they don't all have access to mental health services, which is why it's important that we make sure that those are provided there. And additionally, the recommendation is that there be no more than 250 students to every one school counselor. And that's a national recommendation. When the LRC did their latest assessment in 2021, Kentucky's ratio was 457.8 students to every one school counselor. And so because of that, we of course have the School Safety and Resiliency Act, which was passed in 2019, which did make that recommendation that, requires Kentucky schools to have that 250 students to one counselor ratio, but it did not provide any funding for that to actually occur. So in 2022, that same statute was revised to require schools to provide the Department of Education the number of mental health service providers that they have, what their credentials are, what their duties are, and the amount of time that they are in each of those duties. And additional information like that, still no additional funding for those mental health service providers in the school. But Kentucky's Medicaid program can provide additional funding. And with that funding, that could employ additional mental health service providers. So what we are hoping to do is, with those 171 school districts that we currently have, 165 are participating in school-based Medicaid services. But of those, only 57 are participating in the expanded access program. That's only 1/3, but it is up from 34 the first year. But again, only 1/3 are participating in that expanded access. And if you think of that, that's going to be where those counselors or school psychologists are going to be able to say, these are the services we have, that the mental health services that we have, and have it open to all of the students to make them comfortable to come in and make sure that they're getting those services. So that makes our priorities within the maternal and child health branch to increase the school district participation in expanded access, to bring it up from that 1/3 rate. We also want to recruit behavioral health professionals for school-based services, and there's some ongoing initiatives for that, but also to promote the behavioral health services that are available to students, to make sure students know that they do have a resource within the schools to get those services. And if you need any additional data or information on that, Joe is our school-based services coordinator, and I have his contact information there. And you can also reach out to me, and my email is there. And I wanted to open it up if anyone has any questions on anything that I've presented today.
This may seem like a silly question, but is there any possibility that this mandate is going to be funded by the legislature?
I don't know, but I would speculate that asking for the number of mental health service providers and for the schools to report that could be it could be a possibility that would lead into some potential funding if they saw that there's a low number of mental health service providers and that there would be no way to reach that ratio of 250 to 1 without funding.
Okay, and is there anything this group can do to help make them I'm sorry, is that a recommendation that we need to make from the MAC or to the MAC so that they can take that forward? Or how can this group help with that?
I will leave it to leadership on what should be taken to the MAC. For this group, I would say whatever we can do to assist in making sure that any mental health service providers know that there's a need within the school systems and could maybe contract with schools if they're not already doing that. Not all mental health service providers are employees of the school districts. In some districts, they are just contracted. And so as long as mental health service providers know that that's an option as well, that would be great.
This is Stuart on with WellCare, and I don't mean to crash in, but a note as far as making a recommendation. You talk about making a recommendation to the MAC that the legislature, I guess, would appropriate funds. Just to note that next legislative session, the 2024, is a budget session appropriation where they do stuff like that. So you could be setting the groundwork for next year, basically. Just a note.
Okay, thank you
Sure.
for clarifying that.
And just keep in mind the program itself, the extended care in schools, is a way to bring money into the schools for those services. So it will theoretically pay for itself. So getting somebody, getting the legislator to appropriate funds is not necessarily a barrier if they haven't, because school systems, just like Erica said, can hire behavioral health people that will, see kids and then bill Medicaid for the kids and then cost share to round out the money.
Okay, if there aren't any additional questions, I will turn it back over to you, Kelly.
Thank you, Erica. Thank you for that presentation. I think the next part of old business is the reports from the MCOs on vaping, e-cigarettes, prevention and treatment resources available. Would anyone like to get that?
This is Kelly from Aetna. I don't mind for Aetna to go first, but I do need to have the ability to share my screen, pretty please. Okay, you should have it. All right, so we put together just a brief presentation. We are going to walk through a little bit of data that we have both from internally here at Aetna, but also other sources. And then we'll just quickly kind of highlight the resources that we have to help serve
our youth who may be using e-cigarettes or who may be using tobacco. Right here, we really cited some data that we had from our partners, Kentucky Youth Advocates, in their partnership with the Foundation for Healthy Kentucky. They actually surveyed middle and high school students in November and December of 2020 to gauge the youth's beliefs around tobacco use and how recent policies are impacting tobacco use. And they surveyed about 400 youth from 22 different counties in Kentucky, and that included our far eastern, western, and southern parts of the Commonwealth. And so the bullets that you see on the screen are really from that survey that really noted that there may have been a decline in the use among children and teens in the survey, but we know from data, right, that some of that usage has actually doubled. And according to the survey, students said that the pandemic actually led to an increase in vaping. More than 14% of youth in Kentucky said they believe that e-cigarettes are actually safer than traditional cigarettes, which we think is important to note. And then in addition to that, there was a 2019 youth risk behavior surveillance report, and that showed that 26% of Kentucky high school students and 17.3% of middle school students used a vape product for at least one day in the 30 days prior to the survey. Nationwide, the results for that were 32.7%. In terms of internal data that we had, we were able to pull some data. This is from encounters and claims. And we always like to give a disclaimer that there can be a lag in our claims data. Providers do have quite a bit of time to submit those to us. So I always try to let folks know that before we present it. But we are looking at claims report by year from 2018 to 2022. And this is showing us whether or not e-cigarette usage was noted on the claim. So we saw in the review of claims, only 57 children or adolescents that had a claim with a diagnosis of a vaping related disorder or nicotine dependence disorder or other tobacco products has actually been received through us in the last 5 years. So that's an incredibly low number. What the slide reflects is our healthcare encounter data that may be related to e-cigarette or vaping usage or products that are associated with a lung injury. And this means that the claims had one of the diagnoses associated with a lung injury due to vaping on the claim. So it was kind of the best way that we could pull some data for folks to look at. We did use the ICD-10 official coding guidelines that are related to e-cigarette or vaping or product use. And we just want to again call out this data may not be exhaustive, and it may not represent all of the possible reasons that a youth may have an encounter that's related to e-cigarette or vaping or product use. And then we wanted to note that claims data for 2022 is likely not yet comprehensive because there is that lag and providers still have time to submit those claims. They have up to 365 days. So looking at relatively low cost, but again, that really is probably likely due to the mechanism that we have to pull that particular data from our claims and encounters. In terms of the resources that we offer for our youth, all of our youth do have the ability to be assessed by our care management team and our SKY program in particular. All of our kids are actually assigned to a care manager, and they complete a health risk assessment and an outreach questionnaire that does drill down and ask those youth whether or not they are using tobacco products or whether or not they are using a vaping product. Pending the results, of the HRA, our care managers then deploy interventions. So our members have access to psychoeducation. They have access to additional care management services, which may be to direct members to resources such as the Quit Line. We've also got claims education materials that we review with our youth. And then we also have some formalized psychoeducation programs. One in particular is called Catch My Breath. I'll review that. Details of that are on the next slide. And our care managers will refer our kids that do screen that they are using tobacco products and refer them to that psychoeducation program. All of the members, right, that are in Medicaid have access to covered services. So if there are services out in the provider community, care management, right, will refer members to those that may be provider driven. And then I'll walk through really quickly our Catch My Breath program. This is actually an evidence-based e-vaping education program that provides teachers, parents, and other health professionals with up-to-date information that helps really equip our students with knowledge and skills they need to be able to make informed decisions about the use of e-cigarettes. Our partner company, CVS, has a national partnership with Catch My Breath so that everyone can access this information in this program at no cost. So we're able to provide this to all of our Medicaid youth here in Kentucky. In addition to referrals coming from care management, our outreach staff actually reach out to schools throughout the state and other community-based organizations that have after-school programs, and they're offering to facilitate or support that community-based organization facilitating the Catch My Breath program. And the overall goal of this curriculum is to prevent, right, the initiation of e-cigarette use amongst our preteen and our teen adolescents. The program is designed to help students discover that non-use of e-cigarettes is the norm, right, for adolescents, helps them identify reasons why they might start using e-cigarettes, and then recognize those subtle or not so subtle messages that we may see in e-cigarette advertising. Then it's teaching them to practice skills for resisting peer pressure and that advertising pressure to use, and help them decide on their personal reasons, their personal commitment to not use e-cigarettes and set goals for future non-use. The outcomes that we see from this program and that we're able to gather are to ensure that these students resist their own curiosity, peer and advertising pressure, to experiment with e-cigarette usage, and that we're hoping, right, that they understand that e-cigarettes are addictive, that they are unhealthy, and not an as popular product as they think. And then we want to help equip them with the skills and see an intended outcome that they're influencing their friends and their peers as well to not use e-cigarettes. So really spreading the word of the curriculum. I will pause and see if you all have questions from us. I know that's incredibly brief. Wanted to be respectful of that 5-minute time limit. And we've sent this presentation over to DMS to share with the TAC members, but happy to take any questions and send any follow-up information that you all may need.
Thank you. Just a quick question for me. How would a provider be able to refer a patient to this program, or would we just go through a care manager?
The easiest way I tell folks is yes, to go is really to go through care management, but the quickest way to do that is if they know who their care manager is, of course, they can, have those conversations in real time and ask for their care manager to make that referral. If providers are not sure who the care manager is, I always tell folks to call our member services line. It's a one phone number that's easy for folks to remember or have access to, and they can actually warm transfer people over to care managers. In addition to that, all of our providers have a provider relations rep, and so they may already have an established relationship with that person. So if they've got members that they think would be good candidates for that, they can work through their PR team also to make that connection point. And
Okay,
we noted in here, we do work with community-based organizations. If there are folks that, that are interested in us hosting one with, with a provider group or other community-based organization, please let us know. We're happy to expand access to this evidence-based program.
Thank you. Would another one of the MCOs like to present?
Anthem's happy to go next. Sorry. Okay, do you have our PowerPoint or do I need to share my screen? I believe we sent it to Kelly earlier.
You did send it to me. I'm having some technical difficulties and can't get to it. So I've made you co-host and you should be able to share.
Okay, terrific. Okay, is everybody able to see our screen?
Not yet.
Okay. Let's-
It looks like she's frozen. It might be easier and more time sensitive if we move on and come back to
Hi,
Anthem. If
Courtney.
that's
This
okay
is
with you.
Stuart Cox from Anthem. Yeah, she just messaged me. She had a severe computer restart issue in the middle of this. So if we could come back to Dr. Brochet's, we'd appreciate it. Thank you.
Absolutely. This is the day for technical difficulties. I'll tell you that.
Hey, this is Stephanie
Paula McFall with,
from, oh, go ahead.
I'm sorry, this is Paula McFall with WellCare. We're happy to go. If I can share my screen.
Okay, I have made you co-host. You should be able to share.
Okay. All right, can you see the screen? Not yet. Okay. Now we can. I always forget with Teams, you only have to click once. With Zoom, you click twice. Sorry. Shannon Jones from Medical, Senior Director of Medical Management is also on the call, and she will be talking as well as I am. And so we put together some PowerPoint and we'll send after the meeting. Let's see. So Centene Institute, of course, is our corporate owner, and they have what's called a Youth Impact Award that challenges students to learn more about specific health issues. And vaping was one of them in 2021. They had a Prevention Youth Impact Award campaign where they focused on ages 14 through 19, where they were challenged to raise awareness about vaping and e-cigarettes use and take action to promote prevention with the peers and community. So they had a PSA contest. Communication about the contest was completed through social media, emails, and flyers. Students learned about dangers of vaping by developing and submitting a 30 to 50 second public service announcement video. And then current educational materials are provided at all community relation events given to providers to educate members, providers at schools, and community organizations. The winner was the Centene's Ohio plan, and I've included the YouTube video related to that, and it was a very powerful PSA if anybody wants to take a look at it. WellCare's prevention program encourages enrollees to actively commit to healthy lifestyles and support those who are ready to quit, including vaping and e-cigarettes. Enrollees choosing to quit have access to custom quit programs and supports. The program aggressively works to prevent anyone from becoming a user of tobacco, including e-cigarettes and vaping. We actually use Quit Now for our online as well as health coaching product. Additional resources are we have a online resource called My Strength. It's a self-directed online therapy program to help enrollees deal with tobacco use. Also deals with people with comorbid conditions such as anxiety, depression, and other SUD disorders. We have access to non-nicotine prescription meds, care management access with personal engagement and coaching, and peer support. We do motivational text messaging for people. We have incentives driven by HEDIS, tobacco screenings, and dental, vision, and mental health settings. We engage providers to raise awareness to enrollees through the provider manual, newsletters, and website alerts of enrollees and participating in the tobacco program. We have community engagement coordinators who provide enrollees information at WellCare sponsored community events. Now we have a physician on the line, Dr. Melissa Hancock, who's part of this children's TAC for WellCare, and she has some real life examples of success. So Dr. Hancock, do you want to talk through some of those?
Sure. Hey, Dr. Grigsby, it's good to see you on there today. I'm a clinical pediatrician as well as medical director with WellCare, but we screen all kids 11 and older for smoking and vaping. And I have to agree with what Etna said, seems like it's universally thought in kids' minds, adolescents' minds, that vaping is much safer than traditional smoking. So, the marketing departments for the vaping have, done a good job on the kids with that misconception. As a clinician, I have used some nicotine replacement therapy for older adolescents in conjunction with, frequent, if not weekly, visits for follow-up for older adolescents and teens. Probably the biggest success story I have is a parent and child that both were very motivated to quit smoking, and I managed the child's therapy and met with them weekly. And I think obviously support is a big piece. So we also use the 1-800-QUIT NOW in the office, where we have the tear sheets, and our office manager and everyone are familiar with the MCO representatives, where we can refer kids to the various programs. And just, super positive reinforcement for the younger kids who haven't started smoking or vaping yet. And then WellCare's program for, helping with smoking cessation in pregnant mothers. So you get super important, right? The immediate benefits for the neonate without having nicotine withdrawal and, the potential side effects of all that, but also then having potentially a parent who doesn't smoke themselves, which is a big influence on kids starting smoking or vaping, during their adolescent years as well. But yeah, that's pretty much all I had to add.
Okay, well, thank you. I think we'll just dive back into like the other ask, which is pregnant women and teens smoking cessation. We have treated 1,367 members in 2022 who are managed through the smoking cessation program. And with pregnant women, all moderate to high risk pregnant enrollees are referred to case management. The smoking triggers at least a minimum of the moderate risk. Many fall into the high risk case management program. Education is provided to smoking caregivers of infants to protect the infant's health. We provide how second and third hand exposure can exacerbate respiratory illnesses among already compromised and ICU babies, asthma, and complex peds population. We advise the guardians to wash their hands, wear hair coverings, smoke outside, never in a closed space such as a car, change clothing, or wear a raincoat type material when they smoke outside, so that clothes do not need to be changed. Continued education includes examples of ways secondhand smoke exposure can impact ear infections and other respiratory infections, even if the child does not have a diagnosis of respiratory issues. Review vaping is a concern for chemical exposure for child and guardian due to lack of regulations. Advise caregiver to keep vape devices out of reach of kids, and vaping is not a fix for keeping the children away from dangerous chemicals. Advise on the dangers of smoking in the vicinity of any oxygen equipment that is in the home. So Shannon, did you want to add some information on this piece? Maybe she lost connection. So
I'm sorry, I was talking on mute.
Okay.
Can you hear me?
Yeah. Yep.
Apologies. Yeah, so earlier there was a question around referrals for smoking, and Kentucky has its own line, which is monitored in the state of Kentucky with our care management team. So you can call the 800 number, or we also have a mailbox that's set up specifically for providers who can send that in to us. The other thing about WellCare that's special is that we have an OB, NICU, and a complex peds team that all work together. So if we're working with a member, I was just talking to one of my care managers this morning. So she worked with a member during the pregnancy who smoked. She wasn't ready to quit, so we advised her to smoke less, and she did. Once the child was born and put in NICU, she had a conversation, with the case manager following through NICU, and she was at the point of wanting to quit. We knew the stress was going to, be difficult for her having a child in NICU. And so the NICU nurse continued to work with the mother after she left the OB case manager and continued through that. And then again, not necessarily in this case, but with other cases, once they come out of NICU, then we hand them off internally to our complex peds. So I think that continuity of care is really important, especially in talking about the smoking cessation and being able to, other than just giving them a 1-800-QUIT, we're able to follow through and provide that education to the mom and the family.
Thanks, Shannon. So then again, we want to make sure that teens are also included in our prevention. And so we have the Quit Now for assistance. And we also do have 4 pediatric behavioral health care managers that work with families and can provide this as a resource. And of course, in our assessments of case management, we look for gaps in care and needs. And so make sure we include that in our assessment and recommendations to help people with their desire to quit. And then we also provide counseling through that program. And the program, many people are probably familiar with it, but they have a phone and online program for people that want to do both. Technology-based coaching support, including email, text, and chat, educational materials, quit planning materials, and progress tracking, and then access to community resources online. And then some people who maybe not have access to a computer will do phone coaching only. And that's we provide information by email or mail, quit planning materials, as well as quit progress tracking. And then some just prefer, to do online only, and they can have many access to resources, the quit planning tools, the progress reporting, access to online community and chat with the coaches. There was an agenda item in the children's TAC on featured topics, and we know that Centene has done the same as they did for vaping. They have a contest on anti-bullying, and so we have provided information on this to schools as well as community support. I have not found the PSA that won yet, so when I find it, I will communicate that with folks. But that's kind of the process in which we're looking at some future trainings for education around bullying and cyberbullying. And that's what we have.
Okay, thank you.
You're welcome.
Any questions for them? I think we've had several folks offer to go next. I think Dr. Brashears from Anthem is back after having a little IT glitch. So if you want to continue, and then we'll go to United and then do Humana.
Perfect,
That's
thank
okay.
you. And I apologize for that. Of course, I got the blue screen of death in the middle of everything, so. All right. Can everyone see my screen now?
Yes.
Okay. All right. Well, I'm Danielle Brashears from Anthem. I'm one of our medical directors. I'm going to talk to you today about our different smoking and vaping supports that we offer.
Dr. Brashears, you're showing the wrong screen again.
Oh, well, is it okay? Because the one that's up is supposed to be.
It was there, and now it looks like your email or chat or something.
Okay, let's see.
Share my screen if needed.
Here, let me exit and let either.
Would you like me to share mine?
Yeah, let's let Victoria or Stuart. I apologize. We're having all kinds of problems today.
Okay, who's going to share so I can make
So
them co-host?
Victoria, Jude.
Okay. Give me just a second.
Okay.
I apologize for the delay.
Okay, Victoria, you should be able to share now.
Perfect. Thank you, Victoria. So we have multiple different outreach and programs that we have at Anthem to try to help our various ages of members, either one, prevent them from starting smoking and vaping, and two, to help them quit. We have a member program, a tobacco cessation program through the Truth Initiative, which is a partner for us. They aim at 18 plus through this program. And so obviously pregnant moms would fall, those that are 18 plus would fall under this category. And I'll talk more about this program specifically later. The Truth Initiative also partners with us on This Is Quitting program, and that is a text-based program that is aimed at ages 13 through 24. So there is some overlap in that age 18 to 24 range, but this program provides a little bit more anonymity because it does aim at children, and a lot of them are concerned about parents finding out that they're quit if they're vaping, that they're afraid to reach out through other ways. So this one, we do not collect data through this program. So we do not have necessarily data on how successful the program is, but I'll talk about that a little bit more. There have been studies done, but it is our specific help to quit vaping for this teen age. We also have a health education program. We have an infrastructure of team members who are able to go out into the schools and provide, boots on the ground education to different schools. Again, I'll go through these programs a little bit more in depth in a moment. We offer a healthy reward, which is $75 cessation for anybody who completes the tobacco cessation program. And so if they successfully complete that, they'll get a $75 health reward. We additionally have a value added benefit, and this is actually providing a smoking distraction kit. They get things such as gum, mints, fidget spinners, stress balls, just anything to try to keep their hands and mouth busy for not smoking or vaping. And this is available to anybody who enrolls in the tobacco cessation program. Next slide, Victoria. All right, so as I mentioned, we have a boots on the ground education program where our Anthem associates are going out into the schools. We target elementary, middle, and high school students. There's different programs available based on the age that we're trying to reach out, but in general, we're trying to educate on the dangers and consequences of vaping, reduce the number of people who start vaping, increase the number of people who quit, and then also, making them feel that, they can resist peer pressure, and understanding is not the normal thing to vape, and helping them understand the negative consequences of vaping. Next slide. We have 3 sessions, and they can be mixed and matched or based on what either the school wants or the age appropriateness. A few of the things that we go over are vaping and what chemicals they contain, consequences of vaping. There's a refusal skills workshop where our team members can work with the kids on learning how to say no to help increase, their resistance to peer pressure, and recognizing, the marketing traps of vaping and helping them stop vaping if they already are. You can go on, Victoria. Anybody who attends one of these gets handouts. We have them in English and Spanish. Here are just a few examples. We try to provide more education to those. Hopefully they'll take them home. And if there's a family member who's vaping or smoking at home, they can share it with them. So we can reach more than just the student. We can also reach the family. Next slide, Victoria. As I mentioned before, we have a partnership with the Truth Initiative. They're a nonprofit. They based a tobacco cessation program in partnership with the Mayo Clinic, and they've done a lot of research and evidence-based studying of the problem to come up with 2 different programs. One of which is the This Is Quitting program. The This Is Quitting program, as I mentioned before, is aimed at ages 13 to 24. It's text only. They text a keyword to a number. The only thing they have to provide is their age. They can provide more information to get it more personalized. If that's not needed, they can set a quit date if they want, and then get up to 12 weeks of daily text messages to help encourage them. And then they can also get on-demand support if they feel like they're having stress or cravings to either vape or traditional smoking. Next slide, Victoria. Keep going, please. Okay. So the X program is self-paced, self-guided. They have multiple different ways they can reach out. Like I said, it's mainly for those 18 plus, or it is only for those 18 plus. They can get chatting with either a coach. They can chat with other members who are trying to quit smoking in their community section. They can also get text messaging and quit medication. All of these things are available through this program, which is free to them. Other things that we have for pregnant moms is we also have an OB QUIP program, and the OB QUIP program is for provider-based incentives, but that part of incentive program is for the providers to increase the quit rates of pregnant moms who are smoking. And so by doing so, they get measured on that, and that goes into their incentives. So that's another way we're reaching out. We also are waiting for our 2022 data. We don't have that yet, but we have, we do know that our members are using the state quit line. So I feel like we have various resources, and we're really trying to reach our members through various different ways. Does anybody have questions, concerns?
Thank you. Any questions? It's really positive that there's so much very good work going on. It's nice to hear all the work that everyone's doing around this issue. Okay, if no questions for Anthem, United Healthcare, please.
Sure, if I can get access, I'll go ahead and share my screen. Stephanie Koenig.
Okay, you should be good to go.
Great, thank you. I'm like somebody else. I'm so used to using Teams. Can everybody see my screen okay?
Yes.
Okay, great. Similar to what Anthem Edna presented earlier, our approach really was specific to tobacco use. And so what we have found and kind of the way that we are addressing in the Kentucky market is the approach to tobacco use. And so specific to youth, I think that it is showing up in vaping. And I think the campaign for tobacco, tobacco campaign free did poll the Kentucky, and we were obviously above the national average at like 26% for vaping. And so in addition, the next slide that you'll see really kind of extends further. And when we look at the billing codes that are suggested for vaping, the nicotine dependence is the code to use. We also wanted to include and try to understand our prevalence within cannabis use, as we know that while it's not legalized in the state of Kentucky, there is use of vaping with marijuana, and wanted to kind of try to understand as we are doing more of our HRA core assessment. So this is our overall universe for 2021 and 2022 and the CPT codes that are tied to this. As Etna also pointed out, I don't believe this is a true representation of vaping specifically. It's hard to quantify when there's many different methods to use of tobacco, even in the form of using marijuana, and if that is through vaping. So I don't think this truly represents the actual market in which, or the population and our membership, but this kind of gives you the breakdown of these codes and kind of the high utilization of how providers are billing to treat these diagnoses. We did break it down a little bit further for under 18 for the use of tobacco, and again, using those same codes. And while being newer to the market, our numbers, I think, are lower, and as well, kind of trying to quantify, there was multiple positions on the claim line to really understand is this their primary diagnosis, or have they just been treated for this. In addition, I do want to add, in reviewing and trying to form a true representation of this population, with 0 to 3 population that showed up on the claim lines for secondhand smoke, breastfeeding. So this was kind of how we quantified our population. And our current approach right now is through our HRA. And so there's the core assessment through the screening. We did implement this year the youth HRA assessment. And so the screening questions is asked at the top, screening for the nicotine, or discussed with members' usage. If a member does desire, then we do similar to all the other MCOs, we do have case management that offers, and we do have partnerships as well as with QuitNet for the individualized coaching and smoking cessation. What our case management team has found is obviously some of the barriers, especially with that youth HRA. And for those, youth that may not want to disclose, or a parent is completing the assessment for that use, or we are truly able to connect to those services and trying to take into account. So currently that has been our approach and how we are screening for tobacco use with our membership, and kind of looking at where we are and have been for the last year is evaluating additional opportunities. So our approach is assessing, partnering with QuitNet, with case management, referring to community resources. We also leave one-pagers, leave behinds at community events, provider packets that kind of go over, again, the consequences to vaping and quit smoking, and I'll show you the flyers that are left behind at our community events. Over the course of the next year, we are evaluating a few different opportunities similar to some of the other MCOs. So provider incentive smoking cessation programs, that is in an evaluation right now to implement within our market, as well as a specific tool that assists youth to quit for life. And as it's technology-based. And then the other one is an evidence-based high-touch virtual care service. And there's a kind of 3-tier module depending on the severity or the need. There's both an immediate financial incentive for both the youth and the adult if they do participate. And again, those are 3 different programs we are looking at implementing. Some of the outcome consideration I already discussed earlier when we were evaluating kind of our data and our encounters to our data as well as our claims. It's really hard to quantify this data and become specific to the population. So having to look at not just youth vaping, but looking at tobacco use. And so if we remove or come hard on vaping, what is another method that this youth may use? And moving forward, these are the leave behinds or one pagers. So it does walk through kind of the effects. And again, I think Anthem and Edna both stated, you know, they're based on our research, and I think you do believe that it is a safer method to vape. And so giving some additional education on this. And so kind of the next point of contact, and I think that was a question that was also asked, how do you connect a youth to these resources? And so we kind of outlined the steps to get connected with your PCP, calling member services to get connected, and that's when that HRA would be completed. And then this is the additional quit smoking that kind of connects you to the Quit Now program. Any questions for me? I know many of these programs.
Any questions? So it looks like in your slide, you talk about the resources available for adults, but fewer resources available for children. Are you also, I mean, it looked like that was certainly a handout that was appropriate for adolescents.
Yes, and this is left behind in the school settings. This is one pagers that are left behind at the community events. Obviously, we do have the youth HRA.
Okay.
Will be our meeting with the parents. Part of the challenges and barriers that were pointed out is, you know, in that assessment, is the youth going to be open to disclosing their vaping, you know, just trying to assess what may be the challenges or barriers to get a true kind of Quit Now is predominantly for 18 and older. There's limited resources for the younger population. Obviously, that is with the guardianships agreement. But in our evaluation of opportunities, the second bullet, population specific, this is a smart technology tool that is specific to youth that we're hoping to look to implement this year.
Okay, good. Thank you.
You're welcome.
Humana is ready to present, I hope.
I am. If I could just get sharing, please.
Okay, you should be set.
Okay, thank you. All right. Okay, I am Diana Mueller. I am manager of Humana's Health and Wellness coaching team. I was asked to come today and talk a little bit about our tobacco and vaping cessation health coaching program. You know, health coaching can include quite a wide variety of health and wellness topics. And in Kentucky, we do support tobacco and vaping cessation as well as weight management for youth ages 12 to 17. Humana's health and wellness coaches are highly skilled in many different evidence-based behavior change theories, models, and methods. We facilitate a non-clinical and non-prescriptive coaching program. This allows us to support behavior change, meeting the member where they are and flexing between different strategies until we find what best supports each member. Health coaching creates a very dynamic relationship between the member and the coach that supports the creation of new lifestyle habits and long-term behavior change. We do gladly support members with implementing provider-suggested action steps too. That's always welcome. Health coaching recognizes that each person has unique motivations, values, needs, skills, current behaviors, and challenges, in addition to varying levels of readiness to change. And no two behavior change paths or cessation attempts will be the same. Coaching incorporates all of the items listed to support the member with enhancing their abilities to enact change. The coach is going to get to know the member, asking about their unique circumstances, their future visions, and we help them to set their cessation goals, create small action step plans, and help them to stick to those plans. All right, this is an overview of our tobacco and vaping cessation program for the youth. Our program does include all forms of tobacco products, cigarettes, cigars, vaping, spit, dip, chew, doesn't matter. We'll work with them. Kentucky Medicaid members ages 12 and up with any history of smoking or nicotine use are eligible for participation. The youth program includes 8 health coaching sessions meant to be completed within a 7 to 12 month time frame. So they're spaced roughly a month apart. The program does support people in all stages of change through to maintaining complete cessation of tobacco use. Enrollment in our program begins with a phone call from the member or care manager referral, and program contact information is on the Humana Healthy Horizons Kentucky website. We do schedule the first coaching session at that enrollment phone call, and it's scheduled with both the parent or guardian and the child. That parent or guardian is required on the first call in order to give verbal consent, and then optional on remaining calls. And we do also email out an enrollment packet to the parent or guardian that includes the COPPA direct parent notice and the coaching consent form, but these don't need to be returned. So COPPA is referring to the Children's Online Privacy and Protection Act. Completion of the first 2 coaching sessions within 45 days of enrollment will earn the member a $25 e-gift card, and completion of all 8 sessions will earn them another. And these e-gift cards are rewarded through the Humana Healthy Horizons mobile application. We have had 304 enrollments in 2022 into our coaching program with 66 completions of all 8 coaching sessions. The expected timeline is about 7 to 12 months. So those completions lag a little bit behind the enrollments. In addition, as of March 1st, we still have 183 active participants engaged in the coaching program. All right, the next couple pages are some flyers that we send out to program participants upon request or as an educational need arises during the coaching conversations. This first one is our general program flyer. It does contain our phone number for the Kentucky program. I thought it contained the phone number for our Kentucky program. And we do have a dedicated line so that members can call in. That information is on the website. We have an example of a trifold with some facts about vaping and a youth and tobacco information sheet, an example of one of the items that we hand out during coaching calls. Okay, any questions on our health coaching program? And then we have a couple other Humana associates who might fill in some more information too.
Any questions?
Thank you, Diana. This is Samantha Harrison. I wanted to also incorporate Megan Hoffman into our conversation with the TAC regarding how, much like the other MCOs, our care management team works with membership to refer. So Megan, if you don't mind to open your mic.
Yes, could you all hear me? Good afternoon, everyone. Thanks for having me on. Again, my name is Megan Hoffman. I'm one of the managers with care management at Humana Healthy Horizons in Kentucky. Just to give a little bit more info on how care management plays into this and how closely we work with our wellness coaches. So our HRAs, when they go out to all the members, or if any of our care management staff is on the phone with the member, we're going to try to get an updated HRA or health risk assessment on file, if not already. One of the questions on that assessment does ask if they're using any tobacco or any tobacco-like products, so we can get some more information. If the member states that they are using tobacco, we will explore with them the wellness coaching options. We also, like I said, have members that maybe were diagnosed with something else, and so that's triggering an outreach from a care manager or a care management referral. And then when the care manager looks over that health risk assessment before making the call, they may see that the member checked that they are using tobacco or they are vaping and they would like help quitting. And that triggers for us that we need to have that conversation with them and try to get them linked up with a wellness coach. Also, for anything else, like I said, that members are going to be referred to care management. We have care management support assistants. They run our care management inbound line. So members calling, wanting a care manager for any reason, wanting more information, wanting to get set up with a program, on each and every call, our care management support assistants are going to also go through all of the value added benefits that we offer for our members. And part of that is going to be Go 365 and wellness coaching. So they're going to be talking to them about Go 365 and their Go 365 benefits, how they can get gift cards. A lot of times those conversations will lead to tobacco cessation. So these are just some different ways that we can get the member talking about things they may be interested in. We do always let them know that the wellness coaching, especially for tobacco cessation, is completely voluntary. It does not affect their benefits. So we do have a pretty good outcome of members wanting to be involved. Once the member lets us know that they are interested in learning more about wellness coaching, that they want to be matched up with a coach, it's a very easy process for us. So at that point, all the care manager or care management support assistant has to do is we send an internal secure email to the wellness coaching mailbox. We just include member name, ID number, which wellness coaching program they're interested in, and then the best phone number and time of day or day to reach them. And at that point, a wellness coach will get back to us very quickly. I would say usually same day, let us know, hey, I received your referral. I'm going to outreach this member. After that, when we do our follow-ups with the members, we've heard great things about how they love working with their wellness coach. We can also follow back up with that mailbox and find out who the wellness coach is that is set up with our member. The care managers can then collaborate with them so that everyone's on the same page and we're working together. That's been working really well. And then vice versa, if a member was somehow, set up or called the wellness coaching line, they're set up with a wellness coach, they're having some more medical issues, maybe they're in the tobacco cessation program, but they're telling the wellness coach their main motivation for quitting is because, they've been diagnosed with asthma or they've been diagnosed with COPD. And for some reason, we haven't been able to reach them on the care management side for that yet, then the wellness coach can send a secure internal email to our care management mailbox, and we will have a care manager outreach that member within a couple business days and see if we can enroll them in care management and continue that collaboration process. So that's just a little snippet of how we're all working together and making sure we are reaching all of these members, looking at their total health needs and getting them in the correct programs. Any questions?
Okay, thank you. Thank you guys all for your presentations thus far. As I said earlier, seems to be a lot of great work going on out there. Does anyone from Passport have a presentation?
I'm here. It's Jessica.
Okay.
I'd like to be able
Great.
to share screen, and I'd love permission not to be on camera as someone still without power.
You should be able to share your screen.
Thank you. Give me 1 second, because without power, I am operating in a unique location, making it a little hard for me to, I don't have multiple screens today like I normally do. So give me just a minute. Can you all see my screen? If so, I'll go ahead and blow this up.
Yes.
Great. So I'm going to keep this as short and sweet as I possibly can. I think we've heard a lot about care management programs and other things and health management programs that we all seem to have in common. As a quick reminder, the original question that we heard at the TAC was really around the relationship between behavioral health and nicotine use. That was what was brought up at the last meeting, specifically a belief that, or at least somebody had brought up the possibility that if we could help adolescents stop using vape products in particular, but I think we would all just assume nicotine products in general, that we might see behavioral health improve. This was brought up as part of the continuum for behavioral health needs. So I just wanted to remind everyone, there's really just a correlation, not a causation related between nicotine use and behavioral health. But we do know that there's a likelihood that some of our youth who begin using nicotine products may have a behavioral health underlying diagnosis, but that the kind of that cyclical process of use, with the constant cycle of use, withdrawal, can definitely exacerbate anxiety and depressive symptoms in any population. So that was part of the question. I wanted to make sure we answered it. Like the other MCOs, we know that claims is not always the best way to look at things. So I thought a point in time, this is representing 12 months of claims with full claims run out for those 12 months based on date of service. Just looking at our EPSDT age members 10 to 19 and looking at the diagnostic breakdown, as a clinician myself, the youngest person I was ever asked to treat for cessation was 6 years old. But when I looked at our data, I can tell you that really we start to see actual denominators that are greater than 2 or 3 when we hit age 10. So that's why I started at age 10. But you can see that in general, we're just not seeing a lot of like vaping related disorder diagnoses coming through, but we're definitely seeing a lot of nicotine dependence, unspecified, et cetera, that may be including some of those vaping kind of issues, but it's just not coming through real clearly in our data set. But you can see we definitely have a lot of nicotine use in our adolescents in the Commonwealth, which we know. This isn't surprising. So I was curious to see of all of these claims, how many of these were actually a primary diagnosis, which might indicate that this was somebody who was actively engaged in treatment by a provider related to it. And you can see that that number radically decreases. We're looking at around 44 members total in 12 months, half of whom were 20 years old. So we see a lot of secondary diagnoses when we look at our data for this population. We see a lot of secondary diagnoses with a behavioral health diagnosis first or a substance use disorder diagnosis first, but we don't often see it in the primary spot, which tells us we aren't seeing as much direct cessation work. But I can appreciate that because, again, as somebody who worked in pediatrics a long time myself, pediatricians, we see them do some coaching around this, but they don't always necessarily only bring a patient in for coaching, right? It's part of the continuum of care that they're offering during a well child visit or a sick visit, et cetera. So it's not terribly surprising to me that we're not seeing that. I didn't put it in the slides, but I was, again, always curious about my data. And it was nice to see that we get really great coding from our pediatricians too, related to tobacco exposure, and that we're able to kind of look at that if we want to for our youngest members, because I'm going to assume that while I saw a couple of 0-year-olds with a nicotine dependence diagnosis, that was probably a misnomer and might have been more related to a parent. But when I pulled for codes related to exposure, it was pretty high. And I'm really appreciative of providers kind of giving us that heads up and letting us pull that into our stratification when we're looking at children's needs. Again, we have our care management process. We have a health management process as well. All of our care managers are trained to address tobacco cessation and nicotine cessation in all age members. We try to have them set that as a goal if the member wants to, but of course we're always member centric. So if the member is not interested in addressing cessation or harm reduction, they are going to persistently engage in motivational interviewing throughout the course of their care management process to try to move that member into kind of more of an action stage of change around nicotine use. We of course refer to the Kentucky Quit line, and then we also send teens to My Life, My Quit, or sometimes Smoke Free Teen, which is a great resource because there's a text option there as well. Our CMs have a unique opportunity to refer members that want additional support around cessation interventions to our community health workers. And what makes that extra special is not only are they trained to address tobacco cessation and nicotine cessation, but depending on the location of the member, they can meet them in the community or they can meet them in their home if they need a little bit of extra help and support, which is really a value for especially working with caregiver and teen sometimes. So that's a little added bonus that we have as an option for some of our members, again, depending on their location and if we have one of our community health workers in that area of the state. So that's kind of the care management process as a whole. Our community engagement team has health educators on it, and our community engagement reps are also trained. We partnered with Stanford's tobacco prevention program, and we present those materials in middle and high school, some of which are vape specific. And we work also a little bit with the local health departments too, to try to help kind of, not all local health departments have the bandwidth to always do that for schools. And so we are partnering with local health departments to find out where they don't have as much bandwidth and really directly offer to schools the opportunity to do some of that prevention work in the schools through presentations, et cetera. And then like the other MCOs, we have plenty of nicotine cessation materials. We provide education at our one-stop health centers. So any member that walks in can get some education and actually has manipulables and other things like sitting on tables to learn more about nicotine cessation, but also the damage that nicotine can do. So pretty similar across the MCOs, I think, in general. Any questions?
Okay, thank you. Any questions for any of our MCO presenters? Thank you all so much for this very helpful, all of these helpful presentations.
Yeah, I agree. They were great, thorough, and lots of good information that I didn't know about.
I just
Thank
wanted
you.
to say that if any of the MCOs have not sent in their presentations, if you'll send those to me, and I can put my email in the chat. If you'll send those to me, if you have not already, I will make sure I get those out to the TAC members.
Okay, thank you all so much. Kelly, can you get our agenda back up, please?
Yes, ma'am.
Thank you.
You also have a quorum, so.
Oh, okay. Okay, so I guess if we have a quorum, let's go back and look at have approval of the minutes from the January 11th meeting.
Again, members just need to turn their cameras on.
Should I motion for the approval of the minutes?
Yes, please. And then we need a second. Am I allowed to second as the chair?
I'll second.
Okay.
After we have a motion. Oh,
Okay.
I'm sorry. I thought I did. I motioned to approve the minutes. from
I
January
second.
1.
Okay. And then all in favor? Say aye.
Aye.
Any opposed? And any discussion or the minutes? Okay. Thank you all to all the MCOs. Looking at the new business, again, I think we put this under new business because I'm not sure why we put it under new business, because it looks like it's the same that we had under old business. So skipping through new business, since we will not have those presentations again in May. On to the general discussion and future topic suggestions. Any discussions among the members about topics or requests for data that we need to make for the May meeting? Are there any of these topics that we feel like we need information on from the MCOs or from DMS that we want to discuss in May?
I'm going to ask a silly question as someone who's rather new, I mean, or hasn't ever been to an in-person meeting and only ever done these sorts of virtual meetings. So what other types of formats do we have other than having the MCOs present something? Like if we just want to discuss as a group one of these topics, I mean, I know that maybe we need data or that's all that's ever really happened in the meeting since I've been a member, and maybe that's what we do. But what other formats or is that typically what we like to do, is just get them to give us updates or thoughts or what each is doing for some of these problems?
I can tell you, I go back long enough that I was actually involved in in-person meetings, and sometimes we would invite specific content experts to come and talk about certain topics, particularly if there were topics that may not be being addressed by the MCOs.
I assumed, yeah.
Yeah. So, again, several of these topics, I don't think the MCOs will be doing anything about the juvenile justice issues. And I don't know if that's something we want to visit or we want to wait until after they've had a chance to kind of address some of their issues. You know, certainly bullying, I think, would be, you know, something that we would get information from, you know, schools about. You know, I think of all of those topics that I see, obesity would be the one that we may be able to get programmatic information from the MCOs. But perhaps we want, you know, and content experts to talk about poverty and homelessness and, you know, reviewing those statistics. But that really the presentations that I've seen in the past were either content experts or reaching out to the MCOs or DMS about programs that are in place to address some of these issues.
Thank you. That helps me.
Okay.
Yeah, I think it'd be good to have maybe a content expert about the poverty and homelessness situation to learn more about that, and if there's anything we can do. And
that would be good.
That's kind of always an urgent need.
To maybe take a break from the MCOs having to make presentations, but also to, you know, so that we can target areas of need from those content experts on that topic.
So Alicia, are you still with us?
Yeah, I'm here.
Okay. Anyone from your shop or you that could kind of give us some information on this on a state level?
I can ask internally if anybody feels that they would have kind of the right expertise. When it comes to homelessness, we certainly have been trying to look into this issue. But I would definitely not say we're the experts on it. So there are a couple of other groups that we work with closely on some issues around housing. So I wonder if I could do a little outreach to see if maybe they have somebody that can come and present sort of a broader look at the problem. And then obviously specifically around children in Kentucky, I'm assuming would be probably of most interest to this group. If that sounds good to you all, I'm happy to do some outreach and see if I can find the right person just based on some of the partners I know that we work with.
Sounds good.
That'd be
Yeah,
awesome.
that sounds good. Thank you. And then so do you think that's something that we could get information on for the next meeting in May?
Yeah, I mean, that date's already set, right? Is it May 10th? Is
May
that what I'm
10th?
seeing?
Yeah.
Yeah. With that, I mean, it's still 2 months. I would assume that we can probably get somebody there. I think that's probably plenty of time. But I can try to reach back out to you, Dr. Grisby, probably in the next couple of weeks after I get an answer and we can be for sure on that. Can you remind me, when do we need to have the May agenda set?
I believe it's supposed to be set 30 days ahead of time. Is that correct, Kelly? No, it's a week ahead of time.
Yeah, I like to get them 10 days ahead of time, but a week is acceptable.
Okay, so we got a little bit of time. Yeah, I'll definitely try to get an answer in the next couple of weeks if somebody would be available and willing to kind of come and present to the group. But I'll follow up with you if there's any additional questions around details for that here in the next couple of weeks. Yeah.
Okay. Good. So it sounds like in terms of the next meeting, we will not have an ask for our MCO partners. We're going to give you all a break for the next meeting, but thank you for your presentations today. I don't think there are any recommendations that we need to make from the back since this is not a budgetary year. In terms of the funding for mental health resources, if that's, I mean, that was the one thing that came to mind. Is there anything in terms of recommendations to the MAC that any of the other members identified?
I can't think of anything.
Okay. So MAC meeting representation, I believe, Kelly, do you have the date of that next meeting? I believe those meetings are typically on a Thursday.
I'm trouble getting off mute. It is March 23rd.
Okay.
Which is a Thursday.
Which is a Thursday, which takes Dr. Smith and myself out of being able to attend since we're both
And it is
involved clinically those days. Would any other member of the TAC like to be our representative for the MAC meeting?
Remind me what time they are, Kelly.
It begins at 10 a.m.
Yeah, I can't do that, unfortunately.
Okay. If any of the other members look at your schedule and realize that you have availability and are willing to sit in on that meeting, please reach out to me and let me know. Any other comments or thoughts about, do we all want to stay on the line and just come up with or do we want to touch base maybe later about the agenda for May? I guess we have to wait and see if there's anyone that can present. So perhaps we can touch base in the next couple of weeks about the May agenda.
Okay.
Okay. Any other comments? Do I have a motion to adjourn?
I'll motion to adjourn.
A second?
I'll second it.
Okay. All in favor? I've never heard anyone object
Aye.
to, okay, yeah. I've never heard anyone object to adjourning a meeting. So thank you all for your time today. Thank you, especially to DMS and the MCOs for your excellent presentations. I learned a lot today. I learned there's a lot of good work going on out there around vaping and smoking cessation and tobacco use and cannabis use. So thank you all for all of your good work. Kelly, thank you for taking care of the group.
Absolutely happy to do it.
Will you be with us in May or will Aaron be back?
Aaron will probably be back, but I might be with you as well. We haven't quite worked out the logistics of who's going to do what once Aaron gets back, but I'll probably be on. I just may not be your host.
Okay. Well, thank you again. And Alicia, if you can just email the crew when you get some information, and then maybe we can work on the agenda for May and share that with Kelly. Okay.
Sounds great. Thanks.
Thanks, guys. Have a good rest of your day.
Thank you all. You too.